Hello, I'm Dr. Bryan L from Orlando Orthopaedic Center. I'm here to talk to you today about a relatively common condition of the shoulder called multidirectional instability. Basically, what I like to start with is a little anatomy lesson. The shoulder is a ball and socket joint. The ligaments of the shoulder hold that ball from dislocating outside of the socket. Typically, a dislocation happens with a traumatic event. Say in football, a football player gets tackled and his shoulder comes out of place. It's very painful. You can see initially and right away that the player's hurting. They have to come get that shoulder put back in place. However, there's another condition of laxity of the shoulder where the shoulder can pop out of place without any trauma. There's just looseness of the joint, and that's when the ligaments are very loose. And what can happen over time is it can injure the shoulder and the labrum or the cartilage rim. The cartilage itself or even the ligaments themselves can be injured with all this motion. If you want to come over here to the model, you can see this is a model of a shoulder. You can see the shoulder blade here, the humerus, and you can see the ball and socket joint right here. If I were to take the socket and turn it at the camera, you can see that that would be right here. And you can see that the rotator cuff circles the entire joint and the labrum is attached to the socket. And then what happens is there are ligaments that exit off of the labrum and they come and they attach to the ball like this, and they hold that ball or the humeral head from coming out of place. In some patients that have this condition called multidirectional instability, there's a lot of laxity of the ligaments and the ball can drop out of place or it can come out the front or the back as well. I'm going to demonstrate that today with one of my patients who is a patient who's in her early 30s who's had multidirectional instability in both of her shoulders, and one of her shoulders, her left shoulder, has already been treated, and now I'm going to demonstrate the condition in her right shoulder. Multidirectional obviously means multiple directions, and so this is not a condition where the shoulder dislocates in one direction. It's an ongoing condition where the shoulder comes out in several different directions. And if you look at her x-ray over here, you'll see that the x-rays are normal. Normal ball or humeral head, normal socket or glenoid. It looks normal because it's not a problem of the bones, it's a problem of the ligaments, which you can't see on an x-ray. You have to get an MRI, or you, more importantly, have to do a physical exam to see this. Fortunately, Karen is with us, and we're going to show you that on her shoulders. So as she points her body this way, you'll see this is her shoulder. Obviously, here's her clavicle or collarbone. This is the humerus coming down here. Obviously, the skin and the muscle don't allow me to show you the inside of her shoulder like you saw in the model. But what I'm going to do is show you the looseness of her shoulder or the laxity. So as you can see, as I pull down, you can see it suctioned out. It actually dislocates out. It also can go out the front. You can see that suction. So here's her humeral head all the way out the front. It also goes out the back. And again, more importantly, you can see it going out the bottom. You can see that it's almost like these ligaments are getting stretched out. You can see that right here. Here's the acromion bone, and her shoulder is literally coming all the way out the bottom. I'm going to step in front of her and actually show you now her left shoulder. These patients are growing up, and it's a congenital thing, and they get the laxity of the shoulder, but it's relatively asymptomatic. They can live with it. It moves around a lot, but it's not painful. It's only in those patients where it becomes painful that they come to seek treatment from us. She came to me about 6 months ago, and she had a lot more pain in the left shoulder, and so she chose to undergo a procedure to tighten the capsule. And you can see now it's an arthroscopic procedure with just small incisions. It's very cosmetic, and you can see now as I pull down on her shoulder, it doesn't go anywhere. So it's a stable shoulder. I can no longer dislocate it, and it's a stable condition. And fortunately for her, all of her pain went away. She feels more stable. The shoulder's not moving around, and it feels more like a normal shoulder to her. It was an outpatient procedure. It was about a 6-month recovery, but in those first 6 weeks there's quite a bit more rehab as far as staying in a sling. It limited her quite a bit at work. It's quite a big deal to undergo that, and it was a big decision for her, but she's happy that she's done it. At least she tells me that, and she's actually ready to undergo this procedure on the right shoulder. And as this video progresses, we're going to show you that process and getting her through the surgery, and even some video of her surgery as well. Now, I think it's important at this time to give you a little bit more of the patient's perspective, and to let Karen talk a little bit about her condition and how it's impacted her. So Karen, what made you come to see me in the first place regarding your shoulders?
Well, definitely the instability started getting worse through the years. It's limiting a lot of my physical activity. A lot of the sports and stuff that I choose to do, I can no longer do because the arm would not stay in the socket. Example, my karate, my combat mixed martial arts is something that the arm would just come out, or it's just totally not stable at all. The pain that I started increasing recently, it's just by it hanging, it would turn purple, cold. The pain would just radiate all over the joint, all down my arm.
Okay, and so that's your right shoulder. Now, how is the left shoulder and that surgery, how has it helped you?
I don't have any other symptoms at all. Stability is great. The little bit of time that I was able to do push-ups after surgery, before this one went bad, the stability was incredible. The shoulder was definitely in the socket versus this one I was concentrating on trying to keep it. And just the effort, I spent more time doing that than the actual push-up. This one was solid. Okay. It was great.
I'll go ahead and throw in to the audience that I'm not aware of that I ever gave her clearance to do push-ups, so but by the fact that she was able to do them makes me feel a lot better that left shoulder is definitely stable, and if we can get the same result on the right shoulder, I think she'll be very happy. So I think now, as we do you have any questions for me as we proceed?
Well, definitely. How long would I be out of driving, for example? Sure. I know with the left side, I'm right-hand dominant, so I definitely need to know what I'm looking at as far as, time without driving and things like that.
I think the driving for the right side is going to be more impacted. Most of us can drive with one arm, but at the same time, it's likely if you have an automatic vehicle, you can drive with the left arm and be safe with that. To be completely safe as far as driving with both hands, like I should tell you, I think you're going to have to take 6 weeks off of driving, to be quite frank. But as long as you're off the pain pills, then you can drive, and you can drive safely with one hand on the wheel, and use the other hand for only emergencies. And I think that you'll be able to drive within 2 weeks after surgery.
Okay. How about the exercising? How soon can I get back to my activities?
Well, as you know from the other side, and so the audience knows, it's about a 3-month recovery with regards to your physical therapy. So most of your exercising will be done in physical therapy alone, those first 3 months, and then beyond 3 months you're finalizing your strength, so that by 6 months, like on the left, by 6 months you can do whatever you want. Mixed martial arts, all the weight training you want, and any kind of contact activities you want to do.
Can I start running or walking right after surgery, maybe a couple weeks later? How's that?
Great question. Usually by 6 weeks after surgery, when I feel comfortable that a lot of the scarring has occurred, that the shoulder's not going to, or at least my sutures are not going to be disrupted, then I think at that point, 6 weeks to 8 weeks after surgery, you can do some jogging or lower extremity conditioning.
Okay. My other question that I know that you probably went over this the last time, but I kind of want to get that again. When you talk about the joint and the ligaments surrounding the joint, are you actually going to tighten all those little internal ligaments as well as the rotator cuff?
Great question. In actuality, I don't even touch the rotator cuff. I only tighten the capsule and the ligaments, and I tighten basically all of them, though. The way I describe it, it's like when a little kid leaves his toys all over a blanket. The quickest way to pick up those toys is to gather the 4 corners of the blanket and just pick it all up. And so that's what we're going to do. We're going to gather up your very, very loose capsule and joint, and we're going to put stitches to bring the ligament up to make the volume smaller. And so with that, we're making the ligaments tighter. But yes, all of them. But we don't touch the rotator cuff.
And that's how you use the anchors.
Correct.
Once you take the stitch and you put it in the anchor?
Yeah, we actually, some of them we're just taking stitches and tightening the ligament. Mm-hmm. Other times we're placing an anchor into the bone and grabbing that ligament and pulling the ligament up to the bone, or the glenoid or the socket, so that we tighten the capsule up to the bone to make that volume, basically making the balloon of the shoulder joint a smaller balloon.
Another question that I have for you is, how long would the actual procedure take once I'm under general anesthesia?
Great question. The procedure takes about an hour to an hour and a half to do the procedure. It's all done arthroscopically like your other shoulder. And for the audience, what that means is I make small incisions, I place a camera inside the joint, and I use instruments to pass stitches or sutures and gather up and tighten up the ligaments. And then that way you only make small incisions through the deltoid and even through the rotator cuff, so you don't have to disrupt that muscle. You get to go home the same day. It is under general anesthesia, but we'll make you as comfortable as we can. You're going to wake up with a sling on, and I also use a cold therapy unit to decrease pain and inflammation. That's a cold pad that runs cold water from a cooler up to the shoulder, and it's quite helpful to decrease the need for pain pills. The medication you'll get, and I'll give you those prescriptions now, you're going to get a narcotic pain medication for the more intense pain, which doesn't last long, but it can be present. I will put numbing medicine in your, around the soft tissue of the shoulder as well to decrease the pain as well. I'll also be giving you an anti-inflammatory medication that will help with this swelling, inflammation that also results in pain. And then I'll also give you an antibiotic to decrease the risk of infection. So just like last time, I think you tolerated that pretty well. So I'll give you those. And I think that as far as the procedure goes and some of the details of that, you'll see that on the video that I take during surgery and present to the audience.
One question, right after surgery last time I was in a lot of pain. How many pain pills can I take during that first 24 hours? Because I believe that's the most crucial time as far as the post-surgery pain.
Well, typically a patient can take 1 to 2 of these kind of pain pills every 4 to 6 hours. I don't use any Tylenol in the pain pills, so I think that's safer on the liver. So I think you can count on taking these about 1 or 2 pills every 4 to 6 hours for the first 24 to 48 hours.
Right. Okay. Great.
All right. All right, so we're now in the pre-op area. Karen's ready to get her surgery done. Are you ready to go?
Yes, I'm ready.
Okay, so one thing where that's really important that we do before every surgery is to mark the extremity. So which shoulder are we going to operate on today, Karen?
The right one.
The right shoulder, she said. We confirm that with the paperwork, and then we're going to mark a yes on the shoulder. She'll focus on that, so we've got the yes marked so that we know that we are operating on the correct shoulder. Are you ready to go?
I'm ready. Get
All right.
Get it going.
So now the patient's draped out. You can see this is her right shoulder with some traction on here. I'm going to show you how loose it is when she's under anesthesia. So zoom in here. Here's the shoulder right here. You can see how loose it gets right there as she comes out and goes back in, and then comes out and goes back in. It also can go out the back there, and also it can come out the front there. So she's very loose in all directions, very classically demonstrating her multi-directional instability. The next step for me is to mark my incisions. So this is her acromion bone. I'm going to have to step in front of the camera here like this. And you can see how that shoulder comes out like that. So there's the joint line basically. You can see it's very mobile, very loose. So I'm going to make my incision right about there. Knife, scalpel. So I make a small incision. I use a trocar and cannula to enter into the joint. I'm going to have to move sides with you again here. Now I'm into the shoulder joint. I'll take the camera next. This is an arthroscope or an arthroscopic camera. I'm going to insert that into the joint. We turn on water, so water feeds in, suction out, and that allows me to visualize inside the joint.